Hansen is a 47-year-old African-American male with a history of hypertension who comes in with the chief complaint of searing pain in his left big toe for the past 3 days. He describes it as severe throbbing that does not go away. He first noticed it after a night of partying and drinking with his friends. This pain is aggravated by everything, per the patient, and is relieved by nothing, with a pain rating of 10 out of 10. He has tried aspirin and elevation for relief and denies any injuries to his toe. Mr. Hansen takes hydrochlorothiazide, he doesn't have any drug allergies, and he doesn't smoke. He does admit to drinking 7 to 10 drinks per week and occasionally smokes marijuana. He has a strong family history of hypertension, and his father is currently being treated for gouty arthritis. Upon physical examination, Mr. Hansen's vital signs were unremarkable. He appears to be limping in pain, but well-appearing and dressed appropriately. He is alert and oriented with normal speech. He denies fever, chills, or changes in weight or energy level. He denies chest pain, difficulty breathing, shortness of breath, or coughing. He reports redness and peeling skin around his left great toe. He denies any visual or auditory changes. He denies abdominal pain, nausea, vomiting, or changes in his stool or with urination. He denies any fainting or weakness. He denies night sweats or painful lymph nodes. Finally, he denies depression, anxiety, or any sleeping problems. Patient's head exam is normocephalic. His nasal mucosa is pink and moist, and his pupils are equal, round, and reactive to light. His heart rate and rhythm are normal with no clicks or murmurs heard, and there is no edema noted. Capillary refill is 2 seconds, and pulses are 3+ throughout. His lungs are clear, respirations are even and unlabored. His abdomen is soft and non-tender. There is redness, swelling, and desquamation around the left first metatarsal phalangeal joint. For my differential, the swelling and redness could indicate parenchyma. He doesn't have any recent toe trauma, which makes it less likely that this is structural damage such as a toe fracture. Due to his family history, alcohol consumption, and symptoms, this patient is most likely experiencing an acute gout attack. The patient's CBC, CMP, ANA, CRP, and ESR were all within normal limits. His foot x-ray was negative with no radiographic evidence of fracture or bony lesions. In addition, his drug screen and blood ethanol level were within normal limits. His serum uric acid level was elevated, and his synovial fluid analysis was positive for uric acid crystals. These tests both indicate an acute gout attack. For my plan, I'd like to prescribe colchicine 1 mg by mouth at first sign of an attack, followed by 0.5 mg every hour until the pain is relieved. Prednisone 40 mg by mouth taken daily, tapered over 5 to 7 days, and naproxen 750 mg by mouth at the first sign of attack, followed by 250 mg every 8 hours for 5 to 10 days, and vitamin C daily. I'd also like to incorporate education about diet modification, including avoiding purine-rich foods, increase water intake to prevent formation of uric acid, kidney stones, and alcohol abuse counseling. I'd like to follow up with this patient in 1 to 2 weeks and assess his gout attack.